Maria Cenas, the last 3 letters of my name, and that funny name in the front there. I go by she, her, or they, them pronouns. And I am the Director of Development at the Academy of Perinatal Harm Reduction. I've been doing, working in harm reduction for about over 10 years in all areas of harm reduction, doing housing first, syringe access, yeah. I'm a person with lived experience. I'm a parent, and Joel and I have been working together in harm reduction for the past 10 years. We work together in Seattle, doing Women's Day services for a peer-run syringe access program called People's Harm Reduction Alliance. And Joelle is a NICU nurse, and she can introduce herself. And I'll let you give the brief history of how we came to be, and because you're faster at it, and it includes your main piece of the story. So I'll let Joelle take it away. But I'm really excited to be here, and thanks for asking us to talk. I always get really jazzed when folks from the med school want to learn about harm reduction. I was the volunteer coordinator at Outside In, and so it was really cool because I got to train some med students. So that was really, it's really exciting and fun to like offer you the Kool-Aid and then watch you drink it, but then go out into the world and like prepare the Kool-Aid and then like infect society with it in a good way, like not in a watered down way, like really strong Kool-Aid, not like the watery kind. So without further ado, this is my colleague and dearest friend on the planet, who I love, Joelle.
I love how you took it to the cult, zombie apocalypse, and back to cult again. That was beautiful. So, like Rhea said, I'm Joelle. We've been working in direct service harm reduction for over 10 years now together, in various places and in various ways. I also have been working in perinatal care for 17 years, 16, something like that. And I've worked in all of the inpatient areas. Mostly I like NICU and postpartum because I hate labor, because, you know, somebody could just walk in with a foot hanging out of them and you have no warning. And I like a 5-minute warning on my emergencies. So that's why NICU works really well. Because that foot's coming out in 5 minutes and then I'll be ready. As far as harm reduction stuff, people, you know, when you become a nurse, or probably when you become a student, a med student or a nursing student, people just start assuming that you know everything about everything. So that was how this kind of started for me. I mean, I've dabbled and I've enjoyed all of the drugs that they have. Most of them I've enjoyed. Some of them aren't as much fun. But I didn't really, you know, your training, you get maybe like 30 seconds of substance use training, even though it affects like 20 to 30% of our populations that we serve. So I didn't really know anything. And somebody close to me asked me about cannabis and whether they should stop because they were pregnant. And I was like, well, I don't know. You hear all the DARE stuff, but that's all wrong, right? So I looked into it, and that kind of like got me going on just kind of like a self-study course that's lasted for the last 10 or 12 years. So anyway, so that's me. And as far as this project that we just published, that's not really over yet, that started, so I was working in the hospital and we had a training on our new substance use policy, and I was like, wow, this is garbage. And so I told my boss that it was garbage. She was like, okay, cool, you've been heard, the end. So then I was like, well, let's see, how could I have that interaction go differently? So I just started researching the hell out of it for the next couple of years. And I wrote policies that I thought they should have. And then a couple of years later, when I had that conversation again, they were like, oh yeah, well, what would you do about it? I was like, I'm glad you asked. And I brought like my stack of papers this high, and then they had to pay attention to me. So we got going, and I was able to rework the policies at that hospital. And so then I presented that at a harm reduction coalition, just kind of that project. And I thought I was presenting on how to navigate getting inside of these horrible institutions that seem like you can never change them. But people really were a lot more interested in like the nuts and bolts of it. And I'm like, seriously, like this wasn't hard. I just kind of did it because it needed to be done. But so that kind of got us going. And from there, people kept wanting to hear about it. And then I eventually spoke at a symposium put on by the National Perinatal Association. And from that, this project was born, that we wanted to have a comprehensive guideline for how to take care of pregnant people with substance use. Because the way that we were doing it, all disjointed, wasn't really working. Like the medical side of it wants this as the goal, but that goal is incompatible with the social work side of it. And neither of them are gonna, like both of them are gonna clash with the legal side of it. So our goal was to have something that was, all encompassing, and so that everybody was working together. And also importantly, that it was transparent, that the patient not only knew what was happening, but was deciding what was happening, because that's, what we're supposed to all be doing, right? Patient-centered care and family-centered care, and involving clients in their care plans. So that got going. We were working under the National Perinatal Association for about 3 years. And then we finally had a product and it was ready to go. And, they'd been given copies of it as we went along. But at this point, they were all of a sudden like, screech, just kidding. This is scary. We don't like this. We don't think that we can promote harm reduction. So it was just kind of like a disaster. So then we were on our own for a couple years, and then we've started our organization, well, actually, first we got the client, the Harm Reduction Coalition and the New York State Department of Health. And then we were like, maybe we should start a company. So we started the company, and here we are now. I don't think that was as fast as I do it sometimes, but there you have it. So that's who we are. Do we want to pause for questions before we get into the presentation, or how are people feeling? Presentation?
I just want to let everybody know that I may have to get up periodically, and there may be loud child noises because I'm a mom. So just FYI.
Excellent. So I think.
What's the name of your?
Academy of Perinatal Harm Reduction. And our website has been almost ready to go up for way longer than either one of us is okay with. So if you go there, it'll just be like coming soon. But you can sign up and we'll tell you when it finally arrives for reals.
And
you're muted, dude. You're muted.
Sorry. But either way, even still, please feel free to visit our website, because one of our goals is and pieces is the direct service piece, so which is WoodWorks, which is a mail order syringe access program for pregnant and parenting people that includes supplies, and also a virtual drop-in space where people can create community and build community. And because even within the drug using population, pregnant people who use drugs are some of the most marginalized folks. And so we want to create a space for people to be able to come and access services. So with that in mind, tell your colleagues, fill out go check out our website, and we have a Facebook page. Okay, can you, 1 second? And get on our mailing list so we can stay in contact.
Yes, I didn't mean to undersell it. When it does arrive, it'll be amazing, and you'll want us to let you know when that happens. So please do sign up for the mailing list. Okay.
We're just a little fatigued, but yes.
Start with a brief overview of how the drug war started and how the United States ended up in this position where we export our drug policy all around the world. Ria, do you want to take it away, or do you want me to keep doing this slide? You're muted. Okay, keep going. So the Hague International Opium Convention that was it was kind of like the first official time that the United States decided that they needed to control a population of color. Oh, excuse me, I mean a substance. And what they ended up doing was writing up all these really harsh laws that are very transparently racist when we look at them in hindsight. And at the convention, they ended up, I forget how many, I think by 4 years after this event, 67 other countries had signed on to have similar drug laws. So the practice of the United States kind of pulling this racist stuff out of thin air and then exporting it and making it seem like that's the only way to do things is very old, over 100 years old. A couple years later, the Harrison Tax Act was the first criminal law applied to substance use. So another thing that people don't realize is that the drug war as we know it is pretty new. We haven't been managing what people put into their bodies for most of history. Again, this was a racist law targeting Black, Hispanic, and Chinese people for various drugs that were associated with them. But even at that time, like today, white people and people of other races use drugs at pretty similar rates. But it was always, the Black people with the cocaine, Hispanic people with cannabis, Chinese people with opium. And it followed a very just a cookie cutter format with each of them. Each of these drugs, even though they had wildly different effects, were going to cause white women to become victims, either sexual or otherwise, of men who were not white. And that was kind of how these laws were sold on us. We also see the Marijuana Tax Act. In order to be in compliance and to do commerce in cannabis, you were required to get a stamp from the government, and they didn't issue any stamps. And that was intentional because the way that they interpreted the Constitution at that time, they didn't think that you could make a substance illegal. And so in order to get around that, they did this weird tax thing. And then in 1970, we have the Comprehensive Drug Abuse and Control Act, and that's where they created the scheduling system, which they finally figured out how to make it illegal to possess a substance. But an important distinction to make too is that even today and now, it's not considered a crime to be intoxicated with a substance or to be dependent on a substance. What's illegal is to hold it in your hand. You can get in trouble for possession, but not dependence. So that's kind of a weird loophole that they use to, otherwise presenting for treatment would be illegal if dependence, for example, was the crime. However, we also see in this that a new class of crime has been created that can only be committed by women or other people who can become pregnant. Because in Tennessee and Wisconsin and a bunch of other places, there are laws criminalizing dependence or intoxication with a substance only if you are carrying an embryo or a fetus. And so these laws are by their nature not legal and not constitutional, and can only be applied to people with uteruses, so are inherently gender discriminatory. Next slide. You want to take over here, Ria, or you're muted?
So this this is an article that's just widely distributed and known about, and that sort of piggybacks on that original slide that we were talking, or that last slide, where we start to see the pretty explicit targeting of people of color and associating them with specific drug classes or types like cocaine. And another thing that's important to point out too is that around the time of the Victorian time and Industrial Revolution, there were also doctors starting to implicate women and particularly working class women for drinking alcohol or blaming them. During that time, lots of people were having stomach issues. And it was poor sanitation and poverty, people eating scraps that were causing children to have lots of stomach problems. So the remedy of the day was to provide them with opium to quell their stomach aches. And what was happening is people were blaming women and calling them like, because they were working class women. If they hadn't been working, then their kids probably wouldn't be sick. Whereas instead of looking at and framing it within the context of a public health issue, like not having access to food or sanitation, but instead blaming the women themselves. So we start to see that too. So I wanted to also include that sort of to create the framework in which we're talking about having this discussion. Next slide. So these are some books that we recommend. Our colleague put together this lovely presentation, took all of our information, made the slides. The last book neither of us have heard of, so we don't know what it is, so I apologize. I'm sure many of you have heard of or read Michelle Alexander's book, The New Jim Crow, and then Carl Hart. He is a Columbia professor and researcher who's done a lot of really interesting and groundbreaking work using actual human subjects. And he's a person with lived experience as well. And so he wrote this book, High Price. If you haven't read it, he's done a TED Talk. He did a TED Talk. So like you should check him out because he's a pretty amazing guy, pretty interesting. So next slide. So, okay, so we have this graph here that just sort of depicts the percent of population of people who use drugs based on race and people who use drugs. So we can see here in the green side, for Black folks, use drugs at a reduced rate than their white counterparts, and they sell drugs at about the same rate. And then the percent of people who are actually incarcerated or arrested for drug-related crimes are overwhelmingly Black or African American compared to their white counterparts. And then I can't quite see over to the right, but I think you get the picture, in that there's definitely a disparity, and that the drug war in its inception, when we're thinking about what we've just discussed and then bringing it into today's terms, is working exactly as it should. And a lot of our laws, our Constitution, everything that we're founded upon is working exactly as it should, because it's always been in the best interest of a ruling class or of a specific population of color, people of color. Next slide. Joel?
Remembering to unmute, it's the new challenge of life. Okay, so we know that people of various races use drugs at similar rates, but the numbers for imprisonment of Black people for drug charges is almost 6 times that of white people, and Native Americans is right up there, sometimes surpassing that of Black people as well. We also know that there are just so many instances where these wrongfully accused people have later been exonerated, and a lot of the times it's due to police misconduct, which I hope I don't have to tell to anybody on this call that that's a real thing, and that it happens, and the targets are primarily Black people, Indigenous people, and other people of color. And I think it's important to point that out, because the method that they use to accomplish this goal of white supremacy is the drug war. The drug war, in a lot of its things on paper, isn't necessarily, you can't tell that it's racist just by reading the laws, but the way that the laws are implemented and the history behind where these laws have come from is all pointing it in the direction of propping up and supporting white supremacy. Next slide. So the war on drugs is not only a war on people of color, it's a war on women and children of color. We know that the majority of incarcerated women are accused of nonviolent drug offenses, and that's you can find that from multiple sources. We know that at least 3 to 10% of women who are admitted to prisons and jails are currently pregnant, and that's with less than half of prisons and jails actually testing for pregnancy in their women's population, which I'm just going to repeat that, because when I heard it, my mind was blown. Less than half of prisons and jails test for pregnancy when somebody with the capacity for pregnant is admitted to their facility. And more than 60% of incarcerated women have minor children. This is significant on many levels, but one thing that I think is important to point out is that when men who are fathers are incarcerated, in the majority of times, their children are cared for by their mothers out in the community. But when women are incarcerated, the majority of the time, those children are either put in foster care or doled out to other family members and not raised by their fathers. So what we're seeing is just a generation of children who are being punished because of the war on people who use drugs. We've probably all seen the graphs of how ridiculous our prison population numbers have gotten in the last 40 years. Since the 70s, we've just skyrocketed. And you may know the 70s is right about the same time that we started putting in these drug laws. So the two are not unrelated. And what we also know is that the rate of women being incarcerated is going up at twice the rate of that of men, which is already exponential and unacceptable. So you can check out some of those numbers. I'll take this point to point out, we also have a PDF that all the links work on. So if you disseminate the PowerPoint slides, none of the links work. So we have a much nicer interactive PDF that we can share as well. Next slide. So now we're going to talk about the medical model, as it's called, which is probably some form of this is what they are teaching in school. So the medical model says one thing and does another. So what they say is substance use is a medical condition. It's based in genetics, chemistry, and biology. It's a disease of the brain. Like we've all heard this 1,000 times. What we do, though, is we say people who use substances are untrustworthy, manipulative, and unable to make decisions for themselves. So this was kind of some of the disconnect that I first saw when I was in nursing school, is that we would hear all this stuff like it's a medical condition, just like any other medical condition. But yet, you know, we would turn a blind eye when the patient with diabetes' husband would bring her in donuts. But like, the first time I had to take somebody out for a cigarette when I was a nursing assistant, so like, you know, just a warm body to push her on an IV pole, they said, don't listen to anything she says, don't talk to her, she's going to try to get something out of you. And I'm like, whoa. And we just went down there and she just was, you know, saying, you know, reasonable things like, none of these nurses seem to like me, they all think I'm manipulative, blah blah blah. And then when I got back upstairs, you know, I'm a little 19-year-old, they were like, oh, I knew she was going to say that, try to get you on her side. And I'm like, why are we not on her side? Like, isn't that what we're supposed to be doing? Anyway, so it's just this very weird disconnect, and it's strange that so many people can seemingly have that, just sit with that cognitive dissonance in their head where we say this, but we don't actually believe it. We do this. And it's hard to wrap my head around still. Next slide. So the official definition of substance use disorder from DSM-5, from the American Psychological or Psychiatric, whatever, one of those, from those guys, the DSM-5 guys. So substance use disorder can be diagnosed for 10 different classes of substances, one of which is other. So just, you know, make sure that you don't get too vague with it. There's 11 diagnostic criteria, and it's wildly better than like DSM-4, DSM-3, but it's still a really problematic diagnosis. A lot of the things that in the 11 diagnostic criteria are really subjective. It's stuff like, have you wanted to cut back and not been able to? Have you neglected responsibilities while you were using the substance? I mean, I neglect responsibilities kind of a lot, sometimes when I'm on substances, and sometimes just because, you know, we mess up, we're people. Another issue that I have with this is that they have tolerance and dependence as diagnostic criteria. So we understand tolerance and dependence, right? Tolerance is when you require more of a substance or medication in order to get the same effect. And dependence is when you experience negative symptoms when that substance is withdrawn. So we recognize both of these as predictable physical and physiological effects, not something that should be diagnostic criteria for a mental disorder, right? Those things don't really go together. The other issue is for most classes of substance on this list, tolerance and dependence either don't exist or don't work in the way that we would expect, as with opioids. So, for example, hallucinogens is on this list, yet we don't see tolerance and dependence with those, and we don't have withdrawal. So, does that mean, if you have to get so many to count for, mild, moderate, severe, is that number now decreased for hallucinogens because you can't possibly have these tolerance and dependence? It's just, the more you dig into it, the more it's just a quagmire, and the more you realize that so much of what we're trying to put our finger on and put a nice neat box around, it doesn't work like that. And there's really nothing in here that talks about stress or ACEs or the things that influence substance use that we know about. Next slide. So I just some weird little things to wrap your head around. Substance use disorder is the only condition for which, we already talked about that first one and the second one, medical providers routinely collect criminal evidence against patients. And this is something that I have participated in so many times over the course of my career. We have somebody who comes in and she says, I am on methadone and sometimes I also use, cocaine. And we're like, okay, we're going to drug test you. And it comes back and it's positive for methadone and cocaine. And then we're like, okay, we're going to drug test your baby. And it comes back positive for methadone and cocaine. So why did we do those tests? Did we do it for any reason with the care plan? Are we going to change the way we do her treatment if she's on meth and cocaine, or methadone and cocaine and heroin? Like, are we going to do something different? No, probably not. Are we going to do anything different with her baby? No. The only reason that we did those tests is to hand them immediately over to either social work or law enforcement. So when we're doing that, we're not acting as an advocate for our patients the way the American Medical Association and American Nurses Association, and pretty much every code of ethics out there says that we are to do. This is also the only condition where having the condition is used as a reason to withhold medical care. So when you go to get treatment for substance use, very often you're told, okay, you need to be abstinent. So what you're being told is you need to stop having this condition before we're going to treat you for it. Or you go and you're doing okay in treatment for a couple weeks, and as we know, even DSM-5 says substance use is a condition for which we expect relapse. Relapse is a part of everybody's recovery usually. Yet in so many programs and in so many clinics, if you have a relapse, you're fired as a patient. So it doesn't make sense that if you're asking for treatment for something, which is a chronic relapsing condition, when you have a chronic course and you have multiple relapses, you get kicked out of care. So this is just going back to holding those two ideas in our head at once, that this is medical and yet that's a bad person. We also see employment, housing, parenting, student aid, social services. All of these things are withheld for people that have this supposed medical condition, and we don't do that for any other medical condition. So what's a real model? Because obviously even even proponents of the medical model don't believe it, because it's not what's happening. So next slide. These are some quotes that we've pulled from authorities, and I think Ria is going to talk about them. We just want to talk about how stigmatizing the language that we're accustomed to hearing about this topic can be. Go ahead.
I also wanted to piggyback on something that Joel was talking about too. It's really interesting the amount of expectation and burden that we place on people who are experiencing substance use disorders. I can't tell you how many times people that I serve will have periods of remission, and then they'll come in and feel like they want, talking about suicide because they feel so terrible that they have relapsed. And I'm like, okay, well, where in the history of anything ever, where people are trying to change behavior, do we have these such outlandish expectations of them, to where they're internalizing so much stigma and shame that they feel that they're not even worthy of existence anymore? Like, by the time most of the people that we serve get to us, they've been cycled in and out of institutions, and they've been cycled in and out of drug treatment programs, and most of their dignity and agency has been stripped from them. So their experience of the world is that they have no value anymore. And so, Joelle, can you take the slide while I?
You betcha. All right, I need to move this thing out of the way so I can see. Okay. Sorry, my computer's gonna die. Just a sec. Okay, we're back. All right, so this is a quote from the Association of Maternal and Child Health Programs. The epidemic's impact on families is also reflected in the rising number of custodial changes for children with parents struggling with opioid addiction. In these situations, federal law requires children to be placed in the custody of relatives to minimize trauma. In 2015, nearly 3 million children in the US were placed in the custody of their grandparents, mainly due to their parents' opioid addiction. So firstly, there is no such federal law requiring any such thing. And the fact that, an organization whose job is to specialize in this could get that so glaringly wrong is kind of shocking. And then I invite you all to think about the assumption that we always make that removing children fixes trauma. Because what we know about the foster system, and not that it's not necessary, because it is a lot of times, but it's not harmless. Removing children from their family of origin is, by its very definition, traumatic. And so the idea that it's necessary to inflict that level of trauma on somebody because of what is present or not present in their parents' blood or urine is a really big leap and a really big assumption. It's also assuming that there's no level of services that could be provided to that family to get them into a place where they feel good about their parenting. There's also no asking the family, what do they need? One of our colleagues who's a lawyer has a quote that she always says that's very apt, and it's, the primary funded tool of child services is not parenting support or food support. The primary funded tool is removal of children. And so whatever is primarily funded, that's what's going to be primarily used. Next slide. Ria, you ready?
Yeah, and I also wanted to point out that if you look at sort of the foster care system, it's very, very aligns neatly with a lot of the child removal that we see of Indigenous people, and placing them in boarding schools. So there's again, we're laying the sort of groundwork and framework within context for you to see sort of how we operate as a society, and how we have so much implicit bias around this issue, because it's generational learning. Even within the medical industrial complex, it goes all the way back. And so there's no real, it's very confusing, right? Like we were talking about with the medical model way of seeing things. I think another thing I wanted to say about that is it's a very easy go-to, because it sort of absolves us of responsibility as a society and as a culture, and it makes people more comfortable with the idea. Like, if you view addiction as a disease, then that person, it can't control it, and so we should feel bad for them, right? But again, there's a cognitive dissonance, and what ends up happening is completely different. More on that in a minute, though. So this is sort of a quote that kind of piggybacks like the complete confusion and absurdity of medical care and specific to treating this population. And I'm gonna have to, oh, wait, there we go. So it says consent is not required from the mother to test the infant's urine for controlled or illegal substances if the care and safety of the infant may have been compromised from drug exposure. Staff will explain rationale for and consequences of the test to parents, explain that consent is not required, and request their consent. Now, I'm sure Joelle is going to have something to add on that. I just wanted to say something about this too as well. More often than not, the way that this population is treated by folks within the medical community, I have seen people literally lose their legs, almost choose to lose their hands for fear of being called, CPS being called on them. So it's telling somebody that they you know, that they're going to be tested, but that they don't have to have that their consent isn't required for a test, but that they're asking for it is, I don't even understand the logic behind that. Also, the thing about testing is it's not an accurate, even the testing itself. There's been numerous studies that have been done about the accuracy rate of drug tests. And they're always coming up false positives for things consistently. There's a law that's significant that went through Ferguson versus South Carolina that talks about unlawful seizure and search of people's. And this particular case had to do with collecting urine samples and then sending those of pregnant people who they assumed would be positive for substances, and then sending those samples off to the criminal justice system to implicate them. And so again, we see, you know, this sort of cognitive dissonance where, you know, you're having people, you know, having their constitutional rights being taken, and then having their patient client rights be taken, and then having their families ripped apart, all for the sake of what? Based on implicit bias, and not understanding what your rights are as a clinician, and what your responsibilities are as a clinician, and what it is to be a mandatory reporter and what it is not. And I'd like to add too that there are cases where women have been penalized and gone through the criminal justice system for taking medications that have been prescribed by their prescriber, as maybe they're on methadone and pregnant, and that's the gold standard of care, and they're still being penalized. So I don't know if you had something to add for this slide, Joelle.
I just very briefly, this slide is really interesting because it illustrates that really tricky wording that they like to use. So I want to bring our attention to consent is not required if the infant may have been compromised, or the care and safety of the infant may have been compromised from drug exposure. And so that's, not only is it very vague, but it's also really hard to prove, and it's also something that nobody actually ever does. I never in all my years saw anybody give a reason for drug testing an infant, except I suspect the parent was using drugs, and that is considered to be enough. I suggested in my policy rewrite that I did at the hospital that we put in here, before any test is ordered, document why you have a care and concern that the infant might be compromised from drug exposure, and that was shot down. So what we see a lot of times is people just presume this. Now, if you know anything about somebody who's 2 hours old, their care and safety is very unlikely to have been compromised, because you can't really do that in 2 hours while you're, you know, getting your vagina sewn up or whatever it is that they do. So it's really absurd, but it's also, no, we don't interrogate this stuff. Like, we don't ask these questions. Like, how has this infant's care and safety been compromised? Why are we collecting its very first urine and feces? And oftentimes we don't really have a reason. So that's what I have to say about that. Pick stuff apart and ask these questions. Make yourself that annoying person in your unit. Next slide.
Okay, so this is a slide that we chose just to sort of demonstrate the level of bias that's written into policy, and that our legislatures are using, and it is culturally appropriate, and just to demonstrate that the policy in general. So in the event that there are provable violations of any such protective court orders, the state will further prosecute on a contempt basis and seek incarceration in order to incapacitate the drug or alcohol addicted expecting mother. And I also want to add that there's just now a case that just left California, where there are, I think it's 23 states in the United States have fetal assault laws on the books. So if you end up going into preterm labor, or having any complications, and you're found to have substances in your body that can implicate you for a crime. And we all know that correlation does not mean causation, right? So like the anomaly of pregnancy and childbirth in and of itself is so wacky and wild and weird. And the fact that any of us are really sitting here right now is pretty miraculous. And so to create sort of this correlation, that the two things can become conflated, and there are lots of reasons why pregnancies go wrong, and there are lots of reasons why you can do everything right in a pregnancy and still end up having complications. Conversely, you can be a person with a lot of money who goes through in vitro fertilization treatments and ends up in the NICU delivering at 25 weeks because you have octuplets. So should that person be implicated in the same way? Because there's a certain level of risk that you're assuming. And one could argue that there is that's causing harm on or strain on the fetus because of the fetal environment. So next slide.
Before we go into that, we're going to talk about the actual effects of substances on pregnancy and fetuses in a second. I know it's getting kind of late, so we're going to try to be quick as we go through the rest of this. But it's not practical or ethical to try to hold pregnant people responsible for having a good outcome, because there are so many things beyond our control. Something like 6% of pregnancies result in fetal anomalies. There are all kinds of things. You can get rates of preterm birth are, I think, over 10% now in the United States. So it doesn't make sense to look at these things and say, oh, she used this drug. We can stop looking. We know what the cause is now, because these things are so big and are not, and the science isn't really there that they're caused by the substances either, but we'll get into that in a second. Can I do this last one, Maria? This one's my favorite. I know. So this is in the main work from the American Academy of Pediatrics about substance use in pregnancy, and this is the one that I always end up butting heads with folks when I'm talking about policy. And I just want to point out the kinds of things that people say and that they can get away with, because for some reason nobody's questioning these things. So they're talking about stuff that people who use drugs do that also puts their babies in danger in addition. So these alters behaviors, which include poor nutrition, decreased access to or compliance with healthcare, increased exposure to violence, and increased risk of mental illness and infection, may place the fetus at risk. So if any of you are being exposed to violence, stop doing that behavior. If anybody is finding themselves having a hard time getting good food to eat because of poverty or food deserts, then stop that. Just stop it. Just have good nutrition. Just stop being exposed to violence. Stop having infections. Why do you keep doing that? Just stop it, because you're putting your pregnancy and your baby at risk. And the fact that we are blaming people who are oppressed for their very oppression is absurd. And we're doing this in our most respected and trusted publication. This was published in Pediatrics, and everybody's just okay with this, and I'm not, as you can tell. Next slide. So the model that we subscribe to is it's the medical model plus. Substance use is of course influenced by genetics, chemistry, and biology, but also environment and culture and gender and connection and socioeconomic factors. Next slide. So Rat Park is a fun series of experiments from the late 70s and early 80s, led by Bruce Alexander. You may have heard of this. It got really popular because of like Johann Hari and Russell Brand and all those kind of like celebrity expert types. And they tended to oversimplify it down to a point where it didn't make sense and it didn't say what it said anymore. But it's still useful to look at these studies. So basically what it was is Bruce Alexander noticed that when they're doing studies on rats and finding out, trying to look at behavior and why people use drugs, and they're having these rats that are in cages so small that they can barely turn around. And in some cases, they have electrified floors so that the researchers can give them negative stimulus at certain points. And they are, rats are nocturnal, so they're kept up during the day and it's dark at night, which throws off their circadian rhythms, and they're socially isolated. They will use drugs until they die. Like if they have a water canister and a canister with, cocaine, they'll just drink it until they die in these studies. And so these were kind of used to fuel the crack myths and the crack epidemic, where we demonized free-base cocaine as opposed to powder cocaine. So he was like, well, what would happen if we didn't put them in a horrifying, traumatic environment? So he created this really big, it was like the size of a whole giant science room or whatever, science lab. And there were toys and like good food to eat, different kinds of food to eat, other rats to play with and have sex with. They didn't take the rat pups away from the mama rat. And what they found was that rats who had the option to drink water or use drugs, they used a little bit, like for funsies on the weekends, but they didn't really use a whole lot, and it didn't really affect their health in any way. And so there have been a lot more studies about this, and I just quoted or cited one up there from 2010. And in that study, they found that rats who had even 60 minutes of time with another rat each day decreased their drug use levels to almost nothing. So what to take away from this is not that environment is the only thing that matters in substance use, but it is to take away that environment is an extremely important factor about how and why people use drugs. And one thing that Dr. Carl Hart from the book a few slides ago took away from this was the idea that if people or animals are presented with multiple pleasurable stimuli, what will they choose? And what we can do to extrapolate that to humans and human behavior is that if you have no prospects for advancement in a career, if you don't have good family relationships, if you're not able to get exercise and good food, if you have nothing to do that feels good except drugs, then that's probably what you're going to do, because humans seek behaviors that feel good and that are pleasurable. And so when Dr. Hart did his studies, he offered people who were long-time users of methamphetamine or crack or various other drugs, he would bring them into the lab and they would live there for a couple days, or they'd come in for several hours every so often, and he'd offer them either a hit of crack or a gift certificate. And what he found was the higher the amount of the gift certificate, or he even did cash as well, then people would choose drugs less and less. So that tells us that people who use drugs aren't these mindless zombies that are just going to, sell your mother's TV for your next hit. If people are offered options, they choose things that are good for them. And that's something that's really important to remember as you're working with patients, is that your patient doesn't want to, be the train wreck you see before you. if that's the case that it may be. They want to make good decisions for themselves, and believing that about people is a concept called unconditional positive regard. You should look it up, but I need to keep moving. Next slide. And we can skip this one too. It's a kind of simplistic video. I think it's useful for introducing these ideas to the general public, but I'm hoping that people that are studying medicine will be able to just read the studies instead of the stuff for everybody else.
Before we dive into the actual substances, I just want to sort of also kind of drive home the point. So we have the medical model, and then we have the biopsychosocial model. And so one of the things that this model does that makes it so difficult for people, again, like I said before, is that in order for us to look at substance use disorders through this lens, then it forces us to change our institutions. It forces us to look at what we value as a society, because at the root of the root of the root of all of these issues, if we're looking at it through this lens, then we see and we know that it's capitalism, individualism, and especially tribalism, well, and neoliberalism too, on the counterpoint of that, but the patriarchy. So like all of our laws and ideas are founded in in patriarchal and white supremacist sort of values. And so if we look at substance use disorders as a social illness or woe, and we know that people are using stimulants are of particular interest because people are using stimulants at higher rates now. Well, if there's, especially in Portland, I was pretty astounded. I worked in Seattle for a number of years and was shocked at what I saw here when I got to Portland. But there's a lack of services here for people. There's a lack of housing first services. There's a lack of low barrier services for people here in Portland. And so it's kind of hearkening back to what we were talking about before, where in order to get into shelter, you either have to, you have to be stripped of all of your agency, and then you have to go to a church service, or you have to be sober, or in order to have housing, you have to take psychiatric medications. Like there's this sort of idea that there's like the deserving poor, or the deserving, like that you have to have, or the concept of rock bottom. Where humans are adaptable creatures, and so rock bottom is dead. That's what rock bottom is. There's like no that. And then another thing that I wanted to talk about too is the main prescription for what we give people with substance use disorders is not anything based in evidence. It's generally 12-step models, which are free and which are also founded, which can be very useful and helpful for some people. But let's not forget that it's a moral failing. And so it's placing the responsibility, again, squarely centered back at the person who's experiencing this substance use disorder, while at the same time calling it so the biopsychosocial model just says yes, and like we need to, if people had access to housing, then they probably wouldn't have to stay up all night long because they're afraid to go to sleep. And if especially women, homeless women are so incredibly vulnerable. And so if you're out there on the street and you're pregnant and you don't want to go to sleep, you're afraid, you just kind of walk all night long. So if you offer somebody housing, then maybe they're not going to use anymore. And in fact, there have been a number of studies about wet housing, which I'm not sure if any of you are familiar with, where you provide chronic utilizers of emergency services housing, and they stop using and drinking alcohol. In fact, in Seattle, they did this in a pilot project for an agency that I worked for. It saved the city in the first year $4 million. So it's a downtown emergency service center, and the project was called 1811 Westlake. If you're interested, you can look it up. But I'll let Joelle move forward with the other stuff here. Sorry, I just wanted to include that. Actually, I'm not sorry.
Yeah, don't do that unless you want to, and then it's okay. Anyway, so we'll go through kind of briefly the various substances and what we actually know. What you have heard probably even in your classes is mostly just BS. The two substances with the best, strongest evidence for harm to pregnancy or fetus are alcohol and tobacco. So for alcohol, we see fetal alcohol spectrum disorder. Prevalence is estimated 2 to 5% by the CDC, which is probably pretty low prevalence if we're talking about the whole spectrum of effects. There are some estimates up to 10%. And it can be kind of tough because a lot of the stuff that with fetal alcohol spectrum, there's a lot of overlap with other exposures like lead. So we saw lead exposure used to be pretty much universal until unleaded gasoline, but that's a whole other thing. I said I was going to go through this quickly, so we'll go through quickly. We do see increased rates of miscarriage and stillbirth and impaired placenta function. So that means less nutrition going to build your baby. Next slide. With benzodiazepines, there's not a lot of good research on how these are used in reality. Most of the research that I have been able to find is about prescribed benzodiazepines. And these are one of the more popular pills that you can get pretty easily. And we also know that for lots of people that use stimulants in particular, they're all going to have a bottle of Xanax somewhere as well, because what comes up must go down eventually. And so you see a lot of polysubstance use. So when we're trying to break down what is the effect of this substance, a lot of that's impractical, because with the exception of alcohol and cannabis and a couple, and some other different things that might be just for, there are people who are just a one drug person, but that's not the norm. So what we see with benzodiazepines is possibly congenital malformations, but we're not really sure. And there is probably a neonatal withdrawal. We do see this in the hospital, like when babies are intubated for long periods of time or need to be on benzos for long periods of time for other reasons. We do see iatrogenic withdrawal. Next slide. With cannabis, there is no strong evidence of any severe negative effect. Next slide. With opioids, we see neonatal opioid withdrawal, and we like to use that term better than neonatal abstinence syndrome because it is precise and descriptive. I have worked with lots and lots of people who think that you can withdraw from cocaine or methamphetamine, which is not a thing, and infants certainly can't do that. So it's really important not to get it mixed up what we're talking about. And neonatal abstinence syndrome is such a vague term that we can end up creating dependence on opioids as we're treating a baby who, I had a baby that was exposed only to cocaine, and we ended up treating him with opioids for several weeks, which was not necessary from a clinical perspective. So it's really important to be precise about what we're talking about. We're also not talking about, a syndrome is like a collection of symptoms and characteristics and stuff. But when most people think syndrome, they're thinking things that are permanent or long-term. And neonatal opioid withdrawal is just a couple of weeks. I think the longest one I ever saw was like 5 weeks, so like a month. We also know that this is not dose dependent. So to me, that means that there must be something else involved. Fetal alcohol spectrum disorder is also not dose dependent, although there's some research coming out to question that lately. But what that tells us is that if it's not predictably dose dependent, then there must be something else involved. My suspicion is that it has to do with nutrition and stress and all the other things that affect a pregnancy. But we don't really know that right now. What we do know is that long-term outcomes are really similar to peer group. So a lot of the stuff that you hear in the media about these babies struggling for their whole life and, or, if you're more callous, being a drain on our systems and costing all this money, that's not really backed up by evidence. Next slide. With stimulants, we see maybe lower birth weights and decreased gestation. That's really the only thing that there's strong evidence for. And even that evidence is kind of fishy. And part of the problem is that, and we'll talk about this in the next, actually, I think go to the next slide. I think it's, oh no, it's the next one after this. I'll talk about this real quick and then we'll get there. So when we're doing research on people who use drugs, we're only able to research the people who get caught. And the people who get caught are the people that are either already ensnared in our systems or the people that are vulnerable. So we're not really necessarily getting a clear picture of everyone who uses stimulants. We're getting mostly a picture of people who are young, who are poor, who are people of color. You know what? I'm going to rephrase that. Who are subjected to racism on a daily basis, and these are folks who are already vulnerable. So we're not sure if what we're seeing in these lower birth weights and decreased gestation, which by the way are still pretty minor. Like, do you really care if your baby's 30 grams lighter than it would have been otherwise? Maybe, probably not. But we're not really sure if those effects are related to the substances themselves or the context in which the people that we're able to study are living. Next slide. So I'm not even going to read all the things that are linked to tobacco and nicotine because there's a lot. I just want to, as a thought experiment, encourage people to think about how we react differently to substances for which there is very little evidence of harm, but that are stigmatized and illegal, as opposed to tobacco and nicotine. So and I'm not suggesting that we stigmatize everything, the opposite. I'm suggesting that we react to everything as if it is a healthcare issue. So with tobacco and nicotine, we know that it can cause all this stuff, yet we don't unnecessarily, we're not taking people's babies away because they smoke cigarettes. Because we recognize that taking your baby away is a far more traumatic and harmful intervention than providing you supports to stop smoking, or telling you harm reduction tips like, well, smoke outside, wash your hands before you touch your baby, smoke right after you breastfeed, and then wait a couple hours. And so we respond to cigarettes with harm reduction and with health care. And so if you're wondering, oh yes, this is all well and good, but how could we do it? Look at cigarettes. We're already doing it. We know how to do it. Next slide. So this is the evidence we don't have. Like I said earlier, we don't have any evidence on affluent populations that are not involved in the criminal justice or social service systems. I've never read a single paper on pregnancy and substance use in these populations. And we know that this is occurring because we know that substance use happens across all races and all classes of society. So that would be really interesting information to get. And I suspect that in a lot of our studies, we would find that we haven't really been looking at substance use at all. We've been looking at socioeconomic status. We also know that bias is inherent in all tests of intelligence and development. This is somewhat more well known in the IQ or intelligence quotient test, that people from other cultures tend to score lower in that. These tests that we use were created by and for white Western cultures. So when we're looking at people who are not from those cultures, it's really important to keep that in mind. Next slide. So some other stuff that we don't know. Why are things not dose dependent? Like I said, I suspect it has to do with those other factors. Next slide. With benzodiazepines, all of the effects that we see are also effects of sleep deprivation and pregnancy. So that's something to think about. Is it caused by sleep deprivation, for which benzodiazepines are a treatment, or is it caused by benzodiazepines? That's why a lot of this research is so hard to do, because people are not just living in a silo and only doing one thing that can have an effect on their pregnancy. Next slide. With cannabis, we already talked about this. There's so many studies where they find that the results are aligned along socio-demographic lines, and it never seems to hit them like, oh well, maybe that's significant. Next slide. And we talked about that already. Next. So with this, especially with stimulants, we are stuck in the crack baby myth era, where sometimes I'll read a paper and their results will be kind of equivocal, but then in the conclusion, it will just be dire. And it will be, these babies are, you know, they're monsters and they're going to be a drain on society and we should take them away from their parents and put their parents in jail. And they reach these conclusions that are just not backed up by their data. And that's a remnant from the crack baby era. I'm looking for a non-stigmatizing word to replace hysteria. I haven't found one yet. If anybody can think of one, let me know. Because I don't want to use a word that comes from uterus.
Catastrophizing?
That's a pretty good one. It's not as fun to say. Catastrophizing.
Well, then
Yes.
you're just a misogynist. That's all I have to say about
Apparently, that must be true. It adds up. Because every 10 years or so we renew it. So we had crack babies, and then we had meth babies, and then now we have oxytots, and then now that cannabis is legal, we're having, I don't even know what they're calling them now. They always come up with a cute little name. But it's just the same story being regurgitated over and over again. And it sells newspapers and it funds studies. And so we need to change that. Next slide.
And it also stigmatizes the children.
Yes.
So even if you're a completely innocent byproduct and your parent moves on to maybe use substances or maybe not, but has no negative consequences, having that label on your head follows you throughout your entire educational career and medical life. And if other people were to find that out, it could ostracize you or other you and create more harm. So
And I think yeah, and we talked about this a little bit more. We do have the evidence, but we know that that's not enough of a reason to tear families apart, and also to deprive babies of human milk. This one gets me especially with cannabis, because the evidence for cannabis is like 100 times weaker for the evidence of harm from tobacco in human milk, and yet the ways that we react are so very different. And we know that the benefits of human milk are decreased childhood infections and autoimmune disorders, decreased risk of obesity, and higher IQ, doing better in school, better behavioral problems, and yet we don't give this opportunity to these babies because their parent uses a substance. It's just absurd. Next slide.
You're mine.
Oh, I have to do one thing really fast. I'm really sorry. But Joelle will talk about harm reduction and then I'll come back and take it away.
Okay.
Take it away.
All right. So this is your textbook definition. Amity, you were saying you didn't really have one. This one it's nice, it's quick, it's succinct. So harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. This is kind of two sides of the same coin. So the first paragraph is about what you do, the practical stuff, and the second one is the why you do it. So it doesn't explicitly say that one of the goals is reducing or eliminating substance use. That is implied as part of it. You will reduce negative consequences associated with drug use if you reduce drug use. So we're totally down with that. A lot of times people accuse harm reductionists of being, wanting everybody to use drugs. And we kind of feel neutral about that. If everybody wants to start using drugs, we'll support you and help you do that in the safest way possible. But if everybody wants to stop using drugs, we're cool with that too. We're basically we believe that people have the right and the ability to choose what's best for themselves. And whatever that is, we want it to be safe. And that's all that harm reduction really is. Next slide.
I wanted to add to that there's a Mishka Turplin, who's a doctor out of Baltimore, talks about substance use during pregnancy, and never in my experience have I ever heard of a person be like, oh, I'm 3 months pregnant, I think I'll start shooting heroin now because that sounds like a really good idea. People don't do that. And so when we're talking about harm reduction, none of the information that we're giving you is to say that we think that people should be using drugs. We're not advocating for or against anything. And the large amount of evidence demonstrates that people actually do stop using drugs during their pregnancy, provided that they're provided with the appropriate social supports and have access to prenatal care and to a provider that they have a rapport with. And what we do know is that in terms of outcomes, positive outcomes, prenatal care is one of the most important things that you can do, is making sure that you get prenatal care if you're in a high-risk population. So that means 35 or over, and this would be a person with a substance use disorder would be considered a higher risk. I don't know if that's for surveillance purposes or because of the socio-demographic impacts that we talked about before too. But I suspect it's more for surveillance than anything else.
Yep.
Okay, so one of the things about harm reduction, we'll go through this really quick, that is really important for anybody who is working with folks who have drugs, and I think it's really important for clinicians to understand, is that all of the interventions that we have today to fight communicable disease like HIV and hepatitis C, all of the gold standard interventions, syringe access or exchange programs, community-based organizations doing hepatitis C or HIV screening. All of that stuff was created by people who use drugs as a response to the HIV epidemic in the 80s. What we realized is that the government wasn't going to take care of us. And so we had to do something to take care of ourselves. And so people started distributing and passing out syringes and creating networks of syringe exchange programs, first in Europe, and then it was brought here to the United States by Edith Springer. And anybody you talk to, depending on where you're from, will argue that their state was the first place to have needle exchange. But the truth is, it doesn't really matter to me. What matters to me is that people are continuing this evidence-based practice. Next slide. So yeah, people who use drugs, they're really smart. You should listen to them. Yeah, so they fought for every single intervention that we now have as best practice, and that includes safe consumption spaces and decriminalization. One of the things I want to talk about was decriminalization. I think it's awesome that we have a decrim bill. One of the things that sucks about it is that, to me, it's not enough, because you're telling a person that they have to engage in coerced treatment in order to access services that should be eligible to them anyway. And so people should have a right to say, I want to be in housing and I want these things. And that's still it's replicating a system of oppression. So like drug treatment centers and large corporate entities function in their own best interests, I should say. Many organizations function in ways that don't actually have anything to do with helping the client or the participant, but mostly themselves. The last naloxone distribution, that's another, Dan Bigg was probably largely responsible for bringing naloxone into the communities and making it a household name now. If you're a clinician and you're prescribing opiates, or you're walking into a pharmacy and you have, you don't even need a prescription, you can just ask for naloxone. You can thank a drug user for that, because that's what drug user networks have been fighting for and distributing for. Good Samaritan laws, thank a drug user. All of those things were brought to you by drug users. So next slide. So one of the things that's really popular now is utilizing peer models. So using folks with lived experience as a way of propping up or getting information to build rapport. It's a shortcut. It's a way for people that have been removed or don't have maybe the way. To me, I think revealing your status is a shortcut. I think that the way you build relationships with people is by seeing who they are, and not by having to like prove that you're worthy. It's making a lot of assumptions that a person is only their substance use disorder. People have vast experiences, and they're people first. and no one ever refers to themselves as diabetic or, you know, I don't know, whatever, slip disc, or I don't know, like name something, but you know, we're not pathologizing human beings. Human beings are human beings, and they have experiences. So harm reduction is many things, and one of them is getting out of the way so that people who use drugs can take care of each other and design the services that they need. So the only way you're going to ever be really effective in creating services or working with this population is if you stop and get your ego out of the way and ask people what it is that they need and what they're looking for. And when you're designing services or systems of care, that you allow people who are impacted, who have experienced all of this harm, all of this evidence that we've just told you about, and you allow them to tell you what's going to work, because that's the only thing. No one's ever forced you to sit down in a chair and not eat a donut when you're on a diet. I don't know. I can't think of an analogy, but next slide. So harm reduction encompasses primary, secondary, and tertiary interventions. Lots of times in public health, we think of harm reduction as a tertiary intervention because we're looking at it as an effort to you know, slow down or stop the spread of HIV or hepatitis C. But when we're thinking about it within the context of pregnancy and parenting, or actually just reproductive health in general, we see that it's a primary, secondary, and tertiary intervention, because if people have the proper supports that they need, then it can stop a lot of harm from happening later down the line. So if people have access to housing, then they're not going to be as stressed out. So maybe that won't impact birth outcomes negatively. If people have access to food, if they're going to see a prenatal care provider, it's really important. Doulas play a really significant and important role in this too, because Project Nurture and organizations like that are fantastic. However, they are not really practicing harm reduction, because the assumption or the requirement really is like you're wanting to abstain from drugs. What true harm reduction is doing is saying, we're going to meet you where you are, and these are going to be the consequences. Unfortunately, there are consequences. This is what you're up against. But having a person that is knowledgeable about social services and child welfare system and the legal system and all of the medical stuff holistically that can help walk a person through all of these different stages is direly needed and doesn't exist. And so we need to start thinking about how we're gonna that's why whenever somebody's like, oh yeah, I'm gonna be a doula, or I'm in the birthing community, I'm like, sweet, help me. So next slide. So harm reduction in action is working with clients instead of for them. Like I said, people, by the time they come to you or have come to me, you know, they're completely stripped of their own human rights, dignity, what have you. And so to tell a person that they have value, or that they matter, or that you're interested in who they are, even aside just building that relationship, is so incredibly valuable. And the outcomes you're going to have are probably going to be a lot more positive, because the person trusts you and will continue to come back. Like syringe exchange, people are coming for the syringes, but it's like a restaurant, you know. You go to a diner and the food might be okay, but you like the atmosphere, or the waitress is really nice, you know, she's interested in you or your day, or you have a good conversation or whatever. So you go for the thing, but you stay for the person or the people. And so creating a space that's really welcoming, creating policy based on clients' needs instead of organizational policy that only serves you, integrating people with lived experience into leadership positions, not tokenizing people. So making sure that people with lived experience who are acting as peers, as that bridge to the community, are not just stuck as that bridge to the community, that not only are they have a seat at the table, but they're the fucking table. You know, they're the bench. You know, they're the ones that are holding the shit together, because without them, you know, you wouldn't be able to fill the functions of your job as well, or be as informed. And then making sure that in states that don't have Medicaid expansion, that that parents or pregnant people have continuing medical coverage. This is especially important when people are on methadone, because once you're on methadone and then you don't have the Medicaid to pay for it anymore, then you're completely cut off. And what does that do? That increases, the risk of soft tissue infections, it increases the risk of overdose, and then you're cycling back into taking a person that was stable and then penalizing them for being poor. It also tells the person that, that we care about them as a society, that we're not just concerned about them as being a human incubator, but as being a person of their own selves, and having their own bodies separate from being able to reproduce or to gestate another human. Next slide. So all of these things are harm reduction in action: access to nutrition, driving people to appointments, accessibility, what hours are you open? What's wrong, Lulu? Come here. My kid's tired. Come here. Come here. Oh, come here.
I think this is the last slide, but
so you can see, we just kind of talked about all that stuff before.
Harm reduction has to be all encompassing, because if you are going to access prenatal care, then you need to be able to have access to transportation to your appointments. So this is kind of just looking at the whole picture and the whole person, because nobody is going to be able to make a positive change in their life, which we've all tried to make positive changes in our lives, whether that is, lose weight or stop biting your fingernails or whatever it is. It's hard, and it's a lot harder to do if you're in a stressful situation. So helping people take care of their basic needs is harm reduction. And next slide. I think that's the last of it. And we've got an hour and a half. So thank you very much.